Good afternoon, everyone, and thank you again for inviting me for this nice meeting. I'm going to give you some tips and tricks how we deal with the difficult, challenging anatomy during the EVAR. When we do the EVAR, the challenging could be at the proximal landing zone, could be at the aortic bifurcation, or could be at the distal landing zone, or could be in the contralateral gate cannulation. So I'm going to go through that each one. Let's start first with the proximal landing zone. The most challenging in the neck could be short, could be angulated, could be conical, or we have a lot of thrombus and calcifications. For the short neck, if the neck less than 10 millimeters, there's no indication or place for standard EVAR. If the neck between 10 and 15 millimeters, it's advisable to use a suprarenal fixation, EVAR with the suprarenal fixations. If the neck is more than 15 millimeters, then you can use any EVAR available in the market. But what we do if the neck is less than 10 millimeters, then you have to switch to the BVAR, FEVAR, or chimney, or use endo anchors. It's always our first choice to go with the BVAR, but the problem is a complex procedure. It requires the maximum neck about angulation about 45 maximum. It's a large profile system. It has a high renal reintervention rate, expensive, and custom made, so it's not suitable for emergency or urgent cases. At this situation, usually we go with the SHEVAR because it's off the shelf. You can use in emergency or urgent cases. It can accommodate more angulation at the renal arteries, and also it can help if you have a small iliac artery because it has a low profile system. But to get a good success with the chimney, you have still to have at least 2 millimeter infrarenal neck to get a good result. And the new neck should be at least 15 millimeter. We cannot compromise that to prevent type 1A endoleak. And the second thing, it's very important to oversize at least 30% when you use a SHEVAR. What about helifix? Helifix, it can be done if you have a short neck down to 4 millimeters. But again, it cannot be used if you have a mural thrombus around 180 degree, more than 2 millimeter thickness, if you have a porcelain aorta, or if you lose the opposition between the graft and the aorta more than 2 millimeter, and of course cannot be used in the NELEX devices. What about conical neck? By definition, it's increase the diameter from the top to bottom 4 millimeters. It increases your chance type 1A endoleak. The best way is to have a low threshold for placing a palmar stent to deal with this conical neck. What about if you have thrombus and calcification? We know that most manufacturers advise against EVAR during the concern regarding embolization, migration, or proximal type 1 endoleak. But is there any evidence? If you look at this paper from Journal of Vascular Surgery, they look at the influence of the neck thrombus on the clinical outcome, and they found no significant influence on the short-term or mid-term EVAR if you have a thrombus at the neck of the aneurysm. What about angulated neck? If you have an angulated neck, the best way you need to oversize 20%, 15% will not be enough. Try to adjust your C-arm, and the best way to use through and through wire to help to adjust your angulations. And again, we use palmar stent if patient develop any type 1 endoleak. Like this patient, he developed type 1 endoleak because of the angulation, which was treated successfully with a palmar stent. In experienced center, EVAR with a severe angulated neck is still safe, and the result is usually equivalent to the match control cases. So what is the second challenge during EVAR? You can have a narrow aortic bifurcations. By definition, narrow aorta, if you have less than 20 millimeters, and the problem, it can cause limb occlusion. So what the solution? First solution, you can crack the calcification at the bifurcation by using kissing balloon after you deploy the EVAR, or you can do bilateral iliac stenting, or you can do aortic iliac device with a FEM bypass. But the other options, you can use the endologic APX because the unibody endograft, because this EVAR is usually set at the aortic bifurcation, and there's no limb competition, kinking, or compressions. Or you can use the Incraft from the Cordy system because it's a low-profile system. What about if you have a common iliac aneurysm, problem distal landing zone, you can just coil and cover it, or you can use a bell button technique, or you can use IBD or IBE. But the problem is that 33% of the people will not be candidate for IBE or IBD because of the anatomy. Then you can use a sandwich technique. Last thing, I'm going to talk about contralateral gate cannulations. This could be a difficult, could be a time-consuming. It increases your radiation exposure, could be difficult if you have a large aneurysms, especially if you have a narrow residual lumens. I'll give you a couple tricks. If you have a large aneurysm with a no thrombus, if you deploy your EVAR in the C shape, then the contralateral limb will be inside the aneurysm, be very difficult to cannulate. So the best way is to deploy in the S shape, then become straightforward. The second tip, if you have an angulated neck, again, if you deployed it in the C shape, the contralateral limb will be inside the thrombus, will be very difficult to cannulate, or if deployed in the S shape, will become very straightforward cannulations. The third tip, if you have a narrow aortic lumen with a large thrombus, if you deploy the device completely, then you have no space for cannulation. So the best way is just cannulate the ipsilateral partially, so you have a space and you can go right away and cannulate the contralateral gate. You have to have a lot of catheter available on the shelf for cannulation. You have to be familiar with this kind of catheters, or you can use a Destino steerable catheters for cannulations. If you have tortuous iliac artery, the best way cannulation could be very difficult, so the best way to use a long sheath which can bypass all this angulation, and then cannulation become much easier. What about deploying the EVAR in conventional or ballerina deployment? It depends how the wires. If the wire looks like that, parallel to each other, then I go with a conventional deployment to be straightforward cannulations. But if your wire cross each other like in this way, then it's better to do deployed in the ballerina positions, then become easier to deploy the contralateral gate and cannulate it and get a good result. The last thing, you have to confirm you are inside the main body by doing a pigtail twist, or you hook the pigtail at the flow divider, or you can use a mushroom sign by inflating real balloon inside the graft. Finally, if you cannot get access with all this technique, then the best way to go from brachial all the way down, or from contralateral gate, and then go from below, snare the wire, flip it over, and deploy your device. So conclusion, there is increasing number of patients referred for EVAR without suitable anatomy, but in experience center, AAA with unfavorable anatomy are manageable with conventional EVAR using active suprarenal fixation, precise placement, and careful preoperative planning. Available evidence suggests acceptable midterm result even with the challenge anatomy. But always, if you have more than one challenge anatomy, just be careful, and always remember open repair is a good option, especially if dealing with a young patient. Thank you very much.